there is not too much work. Now, we'll be doing MCQs, and hopefully we'll be done in 1 hour. First question is lysozyme. Who knows what's the function of the lysozyme? Is it to split peptidoglycan? Is it a proteolytic enzyme? Does it activate complement? Is it a cytoplasmic organelle? Is released by mast cells? So what could be the most correct response for this? Let's make it more interactive so that we gain more and better. So what do you think the response could be here? Someone says B, proteolytic. Any other responses? Someone says A, splits peptidoglycan. So for the ones who are saying B and A, can you try to justify your answers? Okay, so the correct answer should be A. Now, lysozyme acts as a mild antiseptic. So what it usually does, it hydrolyzes glycosidic bonds between N-acetylmuramine and N-acetyl glutamidase, I think. And so that's how it splits glycan of bacteria. Remember, what happens is that you have the phagosome coming into the cell after endocytosis and fusing with the lysosome, and they form the phagolysosome. But what has been absorbed into the cell, what has been endocytosed into the cell, the thing that has been endocytosed in the cell is a bacteria. Now we know that bacteria usually have a peptidoglycan layer. All bacteria have peptidoglycan layer. The difference is gram-positive have a thicker and gram-negative have a thinner. Now, in order to destroy this bacteria, what is the most plausible mechanism of action? So I have to sort of destroy this peptidoglycan layer, this covering outer shell that is protecting this bacteria. In order to destroy it, I must somehow cut it into bits. And you know that what forms this cell wall, not cell wall, but peptidoglycan layer, is this chain of, I think, amino acids, this N-acetylmuramine and N-acetylglutaminase. So what happens when you cleave this, when you cleave the joints in between these particles, you now sort of end up destroying the bacteria's protective layer. And therefore you end up destroying the bacteria ordinarily. And that was the most suitable response, and that will expand. Any question on that? So usually I don't think it's a proteolytic, but it is a hydrolytic enzyme. Yeah. Any questions? Awesome. So we can move to the next question. That will be question 2. A histological section of an ovarian mass shows a glandular pleomorphic cells with calcified bodies having laminations. The most likely diagnosis is, what do you think would be the most likely diagnosis for this? Yes, someone says D. Also, that's the correct answer. Maybe we can give other tumors that present with sort of calcified bodies, which have a specific name. What do we call these calcified bodies? Yeah, exactly. We call them samoma bodies. Which other tumors present with samomas bodies under histology? Let's put meningiomas. That's a correct response. Mesotheliomas as well. Oligodendromas. Last time we also added one more. also prolactinomas present with the Samoma bodies. Now, for serous adenoma, it is the most common malignant sex-cord stromal tumor. Not the most common malignancy, but under sex-cord stromal tumors, it's the most common. And it predominantly occurs in females in their 50s. So probably after postmenopausal women. And it often produces estrogen and progesterone. So for example, you have a postmenopausal woman and very high levels of estrogen and progesterone, maybe you can query this also with abdominal swelling and all that query. Now, for mucinous adenocarcinoma, what do we expect and how do you expect them to present under histology? So basically, mucinous adenocarcinomas are benign, they are multilobulated, and they're large, and they're lined with mucus secreting epithelium. So I think last time when we were looking at spots, we saw the cystic kind of organ, right? Which looked sort of shiny or had a shiny liquid inside them. That was probably mucinous adenocarcinoma. That could have been a differential there. For the immature teratomas, these are malignant and very aggressive, and they contain fetal tissue and also neuroderm. They are commonly diagnosed before the age of 20. Yeah, so the correct response you guys have given, and that is serous adenocarcinoma. Any questions? Right, we'll move to the next one. And also, maybe just for note, for the serous adenocarcinomas, something that is very telling about its histology is what we call Cole-Exner bodies. Now, for the Cole-Exner bodies, you have granulosa cells arranged haphazardly around a collection of eosinophilic fluid resembling primordial follicle. So Cole-Exner is Callexner bodies. So they kind of look like a primordial follicle. That is very telling under histology. We'll move to the next. The next is number 4. True of end-stage liver disease. I think we might have seen this last time when we were going through, but we can still provide the correct response. So what is most definitive, or which is the best description of end-stage liver disease according to the choices? E, exactly. It is characterized by generalized collapse of architecture with scar formation. And it's usually non-reversible and most commonly results from or commonly as a result of decompensated cirrhosis. I think that is clear. Maybe we can move to the next question. Very common among the pediatric age groups and also diagnosed by means of serological tests. Maybe that's how you try and diagnose cause. Like for example, serological tests will not detect hepatic failure, but they'll detect the cause of the hepatic failure. For example, I can do serological tests for IgM or antibodies against hepatitis. Now they'll detect that there was hepatitis, which probably led to the hepatic failure, but they won't diagnose exactly the hepatic failure. What we'll use probably most likely is under histology is this architectural collapse. No, I'm not totally ruling out histology because you have markers, the aminotransferases, they can also somehow be used to point you towards that direction, but they are not diagnostic or definitive. Because you can also have these markers being raised, and it's not necessarily pointing towards end-stage liver disease, probably pathology that could be resolved. And said end-stage is irreversible. So the most correct response here would be E. Okay, I think we can move to the next if there are no questions. That would be question 7. True about mesotheliomas, except mesothelial cells have the capacity or capability to develop as either mesenchymal stromal or like cells associated with heavy exposure to asbestos, arise exclusively from the visceral pleura. There is a long period of development of asbestos-related mesotheliomas, and there's no increased risk in asbestos worker who smoke. Maybe we can answer this and then go back because it's a question. So someone says C, arise exclusively from the pleura, visceral pleura, which is the correct response. So usually they arise from either the visceral pleura or the parietal pleura, right? Confusing choice that most of us might find ourselves going for is E. There is no increased risk in asbestos workers who smoke. So basically, tobacco smoking is not a risk factor for mesothelioma, and therefore it's true that there's no increased risk for people who smoke and work in asbestos farms, in asbestos areas with asbestos. They work with asbestos itself. But the correct response, which is wrong, because they do not exclusively arise from the visceral pleura alone, they also can arise from the parietal pleura. Now, someone asked the answer to the previous question. We say the answer was E. It is characterized by generalized collapse of architecture with scar formation. That is the definition of end-stage hepatic failure, and that is irreversible, and you find it commonly among the pediatric age group. So we can move to the next question, and that will be questions you're skipping are not anatomical pathology. They're maybe clinical chemistry, histology, other subunits of pathology. So we'll move to question 12. Malabsorption due to effective intraluminal digestion. What is the most appropriate response? So B, pancreatic insufficiency, correct. So you're not producing pancreatic juice. So what happens is you're not able to digest the fatty foods, and therefore you get malabsorption. Now, we also have other causes of malabsorption due to intraluminal digestion. Can we try and put them in the chat? Ulcerative colitis. I think that would probably be under chronic abnormal epithelium. That's a good try. Any other? Maybe we can think in the lines of biliary obstruction, cirrhosis, cystic fibrosis, and also sucrase isomerase deficiencies. So for Crohn's, it's a chronic abnormal epithelium, because you have alteration and destruction of microvilli, and therefore insufficient absorption leading to malabsorption, and leading to malabsorption. We also have tropical spruce, also the same thing, chronically abnormal epithelium, and this time it's caused by bacterium. And then we have Whipple's disease, which is chronic abnormal epithelium as well. So the correct response there will be D. Now, the next question will be question 13. Common pattern of metastatic tumors within the lung. What is the most correct response for this? Waiting for your responses in the chat. I'll give you a second to sort of read through the question. You'll come up with a response A, and you guys have done well. So multiple discrete nodules that are scattered throughout the lobe. That is the correct definition of metastatic tumors within the lung. Now, for B, usually centrally located. Which tumors of the lung appear centrally? Let's try answer that in the chat. Let's give it a try. Between the maybe mention some of the examples of small cells and small cells that So someone says small cell squamous cell carcinoma. Yes, I agree. That is centrally placed. Any other? So that is squamous cell and small cell. Yeah. Also, maybe of note, bronchial carcinoid tumors can be central and also can be peripheral. So for that, it's sort of equilibrium. You can get them anywhere, either centrally or peripherally. Now for apical lobe, which kind of tumors do we typically expect to see in the apical lobe? Let's give it a shot in the chat. So what you would expect to see in the apical lobe are what we call the pancostal tumors. Now, the ones that occur as single large lesions, these are probably adenocarcinomas, and they're found peripherally. Any questions? Great. Let's move to the next. And that number 17. Oh, this is a number. Sorry. I thought this was clean chem. But maybe we can just do it here as well. A 38-year-old male non-diabetic has chronic kidney disease. So the following statements is not true. Maybe we can try give the correct response. Any responses? Maybe I'll give you a minute to read through the choices. Let's give it a try. Someone says D, yeah. He's likely to have a high plasma calcium level due to increased calcium tension. That is false. We expect this person to have high or low calcium. We expect this person to have high or low calcium. Low calcium, exactly. Why do you expect low calcium? I think one of the reasons is to do with a kidney and its functions to do with vitamin D synthesis. And remember what we talked about vitamin D synthesis last time, right? So when you have low vitamin D, you're not able to allow calcium to cross inside the. You're not able to allow calcium to enter inside from the gastrointestinal system into the bloodstream. So the body kind of tends to resort to look for that calcium somewhere else. That is most probably the bone. So what will it do? It will prompt the thyroid hormone, not the thyroid hormone, but the thyroid gland to produce more parathyroid hormone, right? And this phenomenon is called secondary hyperparathyroidism. And now you see you have less calcium, which is now prompting hyperparathyroidism to try and at least get some calcium. And this is what will lead to low levels. Sorry, this is what will lead to low levels of calcium in patients with chronic kidney disease because of its synthetic function of vitamin D. Any question on that? Anyone who has anything to add? hope it's well understood. Okay, we move to the next, if there's no question. Migratory thrombophlebitis is common in the following tumor. Which tumor is it common in? A, great, pancreatic adenocarcinoma. This syndrome has a specific name. Which name is it? This is what we call the Trousseau syndrome. That is TROUSSEAU syndrome, which is also called migratory, or it is characterized by migratory superficial thrombophlebitis, a phenomenon commonly seen in pancreatic adenocarcinomatosis. Wait, I don't think there is more to explain there. Maybe we can move to the next question. So I think that's pretty straightforward. Migratory thrombophlebitis, that is pancreatic adenocarcinoma. That is what you call the Trousseau syndrome. Here we have the question, I think 18. A 50-year-old male is admitted with severe hematemesis, nodular liver, and enlarged spleen. The most likely sequence of the events is, maybe someone can try piece these events together and give us the most correct response. Yeah, someone says A, correct. So what happens is you have chronic intake of alcohol. Then what does alcohol do? Alcohol leads to cirrhosis. And we've said that the compensated cirrhosis will lead to end-stage liver failure. So that is part of the spectrum of chronic liver diseases. Now, when you have chronic end-stage liver failure, it is characterized by the collapse of the architecture of the liver. When you have collapse in the architecture of the liver, what happens? The intrahepatic ducts constrict, or they are closed. Yeah, they collapse. And remember, the portal vein is trying to take blood into this organ, but this blood is not being accepted by the organ. So what happens in the portal vein? A resistance sort of builds up. And when this resistance builds up, this blood, instead of following the portal vein, hepatic portal vein, it will start to look for other pathways that it can follow, right? Instead of going to the liver, because its direction into the liver has been impeded. And now it will start using the collateral roads, or the collateral veins, kind of in an anastomotic pattern. And therefore, this kind of build-up in pressure, this kind of resistance is what you call portal hypertension. Now, as this blood looks for other places, other throats to follow, it will end up in the various plexuses, such as the plexus around the esophagus, right? And what will happen, this blood is coming a lot, more than these veins can handle, or more than these veins are used to handle. And so what will happen? These veins will tear, they will burst, and then they will lead to this sort of Mallory ways. Mallory ways is the tearing, or the tears in the esophagus, right? And therefore, you get this classic presentation of vomiting blood, which is called hematemesis. Yeah, and that's kind of how it flows. We start with alcoholism, chronic liver disease, portal hypertension, esophageal varices, and then Mallory way tears. Also, they can present with ascites, they can present with caput medusa, they can present with hemorrhoids. Now the next question, 20. Currently, the commonest histologic type of bronchogenic carcinoma is? Someone says squamous cell carcinoma. It's a good try. D, so it is adenocarcinoma. I think we said squamous is the second most common. Or at least also someone should confirm that. But the commonest as of now is the adenocarcinoma. That straightforward. Move to the next. Next should be around number 25. So biochemical findings in chronic kidney disease include the following. Let's give this a try. So what do you expect to find? Hyperuricemia, exactly. So we've already ruled out hypercalcemia and we've discussed the pathology behind that, right? To do with the synthetic function of vitamin D, the kidney. Now, how does hyperuricemia come about in chronic kidney disease? Maybe we can start by asking ourselves, what is hyperuricemia? So this is basically elevated levels of uric acid in the blood. Under normal conditions, uric acid is filtered by the kidneys and is excreted in urine. However, in the case where you have CKD, what will happen? The kidneys may not function properly. So what will happen? This will lead to it will not happen properly. This will lead to decreased uric acid excretion. This will result in accumulation of uric acid in the blood. So the kidney is not excreting as much uric acid as it's supposed to. Uric acid is being produced, but not being taken out. So what will happen eventually? There'll be accumulation. Once there's accumulation, we'll have what we call hyperuricemia. That's why it's a finding in biochemistry of a patient with chronic kidney disease. Great. We move to the next. I think that's clinical chemistry. So we can move to 28. Which of the following is not a way to reduce the risk of HIV transmission during sex? What do we think? Yes, taking antibiotics. So I think this we should know HIV is a virus and antibiotics have no effect on viruses, right? It's basically meant for bacteria. HIV is a virus. So it's basically pouring water on fire. We move to the next. It will be number 51. Coronary artery disease, plaque disruption is brought about by. Okay, so remember we said when you have coronary arterial disease, here is where you have constriction of the arteries due to buildup or accumulation of fat or cholesterol inside the blood vessel walls, right? And what happens, sometimes these accumulations or this inner on the endothelium or the inner part of the blood vessel can rupture. Once this inner part of the blood vessel ruptures, what you'll have is a bleed. This bleed will clot, right? It will form a thrombus. And this thrombus will worsen the condition because now the even small or even narrow lumen has become even narrower because there's now a clot, right? Now, what usually leads to plaque disruption? So plaque disruption is simply saying what can lead to this thrombus that has been formed to dislodge from where it has formed. So the thing that can lead to dislodgement of this thrombus is ulceration. When I get ulceration to where the base of the thrombus, where it had formed, this thrombus will most likely break off. And therefore it will go probably upwards and cause strokes and probably problems with kidney, anywhere else that it might lead to. So the ultimate fate or the ultimate thing that causes this thrombus to cut off or break off is usually ulceration. But usually, yes, that's ulceration. Any questions on that? Yes, so D is the answer. That is the answer we came. But if maybe we can get a few responses and see how you guys have reasoned, and maybe you can put your thought process behind it. So that is plaque disruption, right? But coronary arterial disease maybe is brought about by or is worsened by thrombosis, or it's thrombosis is one of the pathologies behind it. What will lead to this disruption plaque is the ulceration. So now the thrombosis is an eye catcher there, definitely. But maybe when we reason it out a bit, maybe we come up with ulceration as a better response. Next question. Number 38. Let's move to 38. Acute liver failure occurring within 6 months of presentation is considered to be, correct response, E, yes, acute. Fulminant within 2 weeks. Acute and chronic, the middle, between 2 weeks, thereabout. And then, no, not 2 weeks, 6 months, thereabout. And then we have subacute. We have viral induced is probably, that is the definition of hepatitis. And then you have acute, that is within 6 months. Chronic, within 6 months. Let's see the chart. Move to the next. So in the chart, they're asking subfulminant. Oh yeah, so subacute, it has entered 2 weeks. 2 weeks. Great. Move to the next. Fulminant less than 2 weeks. Question 40. Acute inflammation characteristically involves, let's put it in the chart. Yeah, C. So So remember, when you have acute inflammation, right, we have an offending, maybe pathogen, right, in a specific place in the tissue. So the first thing, we have macrophages coming there and sensing sort of this insult, basophils. Then what happens next? There's release of inflammatory cytokines. There's release of bradykinin and histamine. And therefore, what happens? These neurochemicals sort of act as chemoattractants. Then we have the neutrophils. The neutrophils are sort of just going along in the blood vessels. And then what happens? You have diapedesis. Now they move from the blood vessels to the connective tissue, to the interstitium. And there they find this cause of injury, this insult. And now the neutrophils come and sort of neutralize this insult. Therefore, when you have these neutrophils coming, this is one of the hallmarks of acute inflammation. Now, let us come with a clarification. Fulminant liver failure is within 2 weeks, and subfulminant is 3 months, right? So we've done that, and we've said influx of neutrophils, sort of the hallmark of acute inflammation. So mast cells, you expect to see them mostly in allergic reactions. Macrophages is a part of the innate immunity. And then you have capillary endothelial enlargement. This allows for the diapedesis, but it's probably not the main feature. Any questions? We can move to the next, will be number 43. Question 43. In the first 10 days of neonatal life, a finding of indirect hyperbilirubinemia is most likely due to 43. So is the most appropriate response for that? Very good question. Yeah, B. So immature gluconeurial transferase. I don't think we'll belabor too much on that. Move to the next question, the one below. Ovarian tumors associated with formation of hormonal effects. The most appropriate response. Brain tumors, clear cell carcinomas, squamous cell. Someone says squamous. Someone says endometrioid carcinomas. Any other responses? So the correct response is E, mucinous carcinomas. So usually the mucinous carcinomas, they have a stroma. And the stroma of these mucinous carcinomas acts as a source of hormone production. And the most common hormone produced in this type of tumors, or in this stroma, or in this, the stromal cells in this tumor, is called estrogen and androsterone. Sorry, not androsterone, but androgen, sorry. So usually estrogen and androgens will be the most commonly produced hormones in the stromal luteinized cells of the mucinous carcinoma. And also, it is the most common non-endocrine cell ovarian tumor accompanied by hormonal manifestations. For this, it will be carcinoma, mucinous carcinomas. For brain tumors, maybe points to note are it is very rare. It peaks around the age of 40 to 60 years. It is similar, or when you look at it under a microscope, it will appear similar to transitional cells of the bladder, the urothelium. It has circular patches of cells with a coffee bean-like nuclei. For the clear cell carcinomas, 5 to 10% are epithelial tumors, or they form 5 to 10% of the epithelial tumors, and they are most commonly present in perimenstrual women. So women in their menstrual age, right? Or before their menstrual age, rather. That is the perimenstrual women. Yeah, and I think we discussed about the serous, the one with the multilobulated, and the mucin inside the serous material inside the cysts, cystic-like holes. And then we have endometrioid carcinomas. I'll be never too much on that. Okay, you're welcome. You can move to the next one. The next one, number 47. The used for pap smears at Kenyatta National Hospital is, which is a responses. Percent from saline, 10% from saline. Any other responses? Someone says 95%, I don't know. Yes, so the correct response is B, 95% ethyl alcohol, which is still the same as ethanol, right? The one that, so acetic acid is used for visualization, and the one used at Ketchup is ethanol, 5%. That's some fact. Maybe we should mind. Maybe the other question you can use was to ask what is the work, but it's to fix the stain. So the answer is 95% ethanol. We can move to the next question. Number 51. During fine needle aspiration procedure, cells are obtained by, how do you obtain cells in fine needle aspiration? What could be the most appropriate response? Yes, exactly. So the correct response that encompasses all is A. That is active suction using the syringe. Active suction using the syringe. Or maybe the choice that maybe could give a bit problems is E, cutting process. This is basically biopsy. It says E. Maybe you can. Yeah, so I think we're all in agreement. Answer is A, active suction using syringe. So we move to the last question. That is question 56. Tumor usually associated with syndrome of inappropriate antidiuretic hormone secretion is, Exactly. B. So which other hormone does small cell carcinoma produce apart from antidiuretic hormone? Mhm. Which other hormone will it produce? You have the adenocorticotrophin hormone. Now, for hepatocellular carcinoma, which marker will be raised? Mhm. Yes, the alpha fetoprotein. Yes, and what is which hormone or which syndrome? What product is secreted by squamous cell carcinomas of the lung? What is the parathyroid related peptide? Related peptide. You can add parathyroid. So PTH, small r, then capital P. Then pancreatic carcinomas. Which markers do we use to look for pancreatic carcinomas? Yes, so we have the C19.9. Yeah, and I think we're done. For renal carcinomas, I think how you diagnose them is by maybe imaging. You can also do lab studies and urinalysis, where you have frank and microscopic hematuria. Right, so to suspect, maybe check for proteinuria and white blood cells, hemoglobin. You can also check this abnormal hemoglobin, reduced number of red blood cells. Maybe hypercalcemia is present. Income, raised UN creatinine ratio, all that. But the correct response for this was B, where you have ADH being produced by the small cell carcinomas of the lung, which is a um, small cell. Maybe as we wind up the last question, maybe we can list the non-small cell carcinomas of the lung. Normal. Any others? Blood cell. Mm-hmm. Squamous cell. Mm, good. Good. So you guys have done extremely well. Um, that's pathology MCQs.